All right, so I just want to talk about the academic otolaryngology and my path and how I incorporated research into a surgical career, which is not the most common thing. And as I was coming along, a lot of people basically said, well, you can't really do that, but in reality you can. So just a little bit about me, so y'all know where I'm coming from. I'm from Winston-Salem, North Carolina, a suburb actually. It was a middle-class neighborhood, and I went to public schools. I played a lot of sports when I was young, almost anything that we could. And you know, like all of you, I'm sure, worked hard and did pretty well in school. So I was at UNC for a long time before, about 22 years. Started as undergrad, did medical school, residency, fellowship, and joined the faculty of otolaryngology during that time. And then I went off to Vanderbilt, and I had started doing otolaryngology as a research and clinical career. And at Vanderbilt, I did pretty much the same thing. They had a laboratory there that somebody had donated some money to help support. And while I was there, I got a business degree at the Vanderbilt School of Management. And in 2012, I went to Yale as the chief of otolaryngology and the director for their head and neck disease center. Head and neck basically means head and neck cancer. It's one of the divisions of otolaryngology, head and neck surgery. And when you see this abbreviation OHNS, that's otolaryngology, head and neck surgery, that basically means ear, nose, and throat. And I was a co-leader for VOICE, which is a program in the Cancer Center for viral and other infection-related cancers. And then in 2018, I was lucky enough to be offered the position of chair of otolaryngology head and neck surgery at UNC. So I came back here, been here, like I said, basically 2 years. So this is the family. The guy with the graduating cap on is my oldest son, and he graduated from Davidson. I don't know why he didn't come to UNC, but anyway, Davidson's all right. And then my youngest son's on the far right. My wife's in between the two of them. A little bit about the Department of Otolaryngology at UNC. So this is Newton Fisher. And he founded the department in 1952. So that's when UNC Hospitals actually was founded too. And a newly formed 4-year School of Medicine was founded at that time. So he's the one that started it. And I actually knew Dr. Fisher. His daughter is on our faculty now, Amelia Drake. So he's quite a legend. And then Harold Pillsbury was the second department lead, and he took the division of otolaryngology and made it a department within the UNC School of Medicine. And then through the years, the reputation at UNC really grew, and except for 2013, it's been the top ranked program at UNC Hospitals. From a clinical standpoint, it's a very busy faculty. It was top 10 in 2018 and continues to be nationally recognized. And then I came in 2018. So really since 1952, there's only been 3 chairs of otolaryngology. So I figure I got about another 30 years left just to reach the average. We'll see if I make it that long. All right, so to get a little bit into the research part, this is something that not many people know about. Awareness is increasing about this new cancer that's HPV positive or HPV associated head and neck squamous cell carcinoma. So squamous cell carcinomas are the type of cancers that occur in the head and neck. And when you say head and neck cancer, what it really means is cancers of the mouth and throat and voice box and nose and nasopharynx. So sort of all what we call the upper aerodigestive tract. And we also do thyroid cancers and salivary cancers, but HPV really is associated with those upper aerodigestive tract cancers. And while tobacco-associated head and neck cancer has been decreasing because smoking is decreasing in the United States, this oropharyngeal squamous cell carcinoma, sometimes you'll see OPSCC, they have been increasing. And those are the ones associated with HPV. They're associated with younger patients, decreased or absent traditional risk factors, tobacco and alcohol consumption, and it's been growing annually at a pretty steady clip. And this was between 73 and 2004 at 0.8. It's even accelerated beyond that. But you can sort of see the start of this exponential growth curve for these HPV positive cancers as the HPV negative cancers are starting to decrease. So when the CDC looks at cancers caused by HPV, usually about every 4 years they come out with a scorecard like this. And the reason I have this slide up is because for the years 2008 through 2012 was the first time that oropharyngeal squamous cell carcinoma was the most frequent HPV-associated cancer in the United States. So it surpassed uterine cervical cancer as the most frequent HPV-associated cancer. So if uterine cervical cancer is a health crisis, then head and neck cancer is now a bigger health crisis associated with HPV. And since 2012, the difference has even increased more. So it's really what some people are calling an epidemic. Every talk like this, I want to mention the vaccine. There's a lot of people at UNC. The CDC HPV vaccine effort is sort of centered at UNC. So there's a big effort to get people vaccinated, but the vaccination rates are not where they should be. They have been getting better recently, but the vaccine prevents carcinoma in situ of the uterine cervix and urogenital condylomas. It's very effective, long-lasting, it's safe, and now currently recommended is the non-valent Gardasil with 7 oncogenic and 2 benign types of HPV covered. The benign types cause warts and the oncogenic types cause cancer. But most importantly for head and neck cancer, there's an HPV subtype 16 that causes almost all head and neck cancer. So this vaccine does cover that and is now approved for prevention of head and neck cancer. So if we can get people vaccinated, you know, it's kind of amazing. There's a vaccine that prevents cancer. We should get everybody vaccinated. But the uptake has been very slow in the United States. So when people look at HPV-associated head and neck cancer, there's been a lot of things that have been known to be difference between those and the ones that are not associated with HPV. And one is survival. So HPV-associated cancers have improved overall survival. So they're this top line compared to the tobacco-associated cancers, this bottom line. And this is progression-free survival. So once again, this top line, and the lines around the top line are just the confidence intervals. And then the bottom line is HPV negative cancers. And basically what you can see is the HPV positive cancers do a lot better as far as survival. Now there's some problems with that because our treatment is pretty toxic for these cancers. And so people, even though they have longer survival, they live with the side effects of the treatment for longer and they're younger. So we're working on how to de-escalate therapy appropriately so that we cure patients, but don't give them the side effects of the normal treatment. So what are the practice gaps? One of the practice gaps is we do not know who to give less aggressive therapy for. It'd be great to be able to identify patients who are going to have good outcomes and those that are not going to have good outcomes, So the ones with good outcomes we can treat with less aggressive therapy. And those with poor outcomes, we can develop new treatments or treat with more aggressive therapies. And so basically we're overtreating some patients and undertreating other patients, and we don't know who is who. So this is one of the things that we would really like to address, and our lab's been working on this. And I showed this that just gives the difference between HPV positive cancers on the left and HPV negative cancers on the right. So you can see the HPV positive cancers are associated with younger patients and a risk factor that's basically sexually transmitted disease. They are more responsive to therapy with a cure rate that's somewhere in the 75 to 80% range. But the gene alterations are what our lab really got interested in. The conserved gene alterations are quite different between these two tumor types, and there's a distinct gene expression profile as well and a more methylated genome. But today what we're going to talk about is these two genes, TRAF3 and CYLD. So if we look at TRAF3 and CYLD, why are we interested in those? Well, one, they're mutated only in HPV-associated head and neck cancer. TRAF3 is a ubiquitinase, and we noted right away that there were some pathways that TRAF3 was involved in, which was regulating immunity. So innate immunity particularly is a epithelial cell's response to the virus. And usually when a virus infects an epithelial cell, it wants to kill itself. And innate immunity enables it to kill itself. If you shut down innate immunity and if you activate NF-kappa B, the cell is more likely to survive. So that's what the virus wants to do, is have the cell survive and have the cell not kill itself. So this TRAF3 gene is a ubiquitinase, so it attaches ubiquitin to different molecules, and that's the way it regulates these pathways. There's deep deletions that are also found in addition to these mutations. And over here on the right, you can see TRAF3 is listed. Almost all of the mutations and deletions occur in this subset of patients that are HPV positive. Almost none in HPV negative. And these are only point mutations. This does not include the deep deletions. Interestingly, these mutations were not described in a database of cancer-associated mutations. So this was one of the first tumors that this gene was mutated in. And we thought that was really interesting. Same thing's true for CYLD, not really mentioned in a lot of tumor types. It's a deubiquitinase, but it does the same thing. It regulates NF-kappa B and innate immunity. So these two genes we think are doing the same thing in this cancer type. So we sort of asked, what are they doing? But we wanted to see if they were mutated in other types of tumors. And so this is the HPV positive subset from the TCGA, which is an effort from the National Cancer Institute to sequence tumors of all different types. And so this is sequencing, and you can see about 14% of these HPV positive tumors have deep deletions or truncating mutations, so that we think all of these are inactivating. CYLD is the same thing. About 14% of the tumors have either deep deletions or truncating mutations or a couple of missense mutations. So basically we think these two genes are inactivated in HPV positive head and neck cancer. But look at HPV negative head and neck cancer. You see some amplification, and you see just a little bit of deep deletion and just a little bit of missense mutation. So these percentages here, about 2% of alterations, including all these amplifications. And the same thing is true for CYLD. When you see a profile like this, it makes you think that there's no really rhyme or reason, because in some tumors it's being turned on and some tumors it's being turned off. You see a profile like this, roughly 30% of the tumors have inactivation of these two genes. So we think there's really something going on in HPV positive tumors. If you look across other tumor types, some tumors have activation of these genes, but really The only tumors that have deletions or mutations are diffuse large B-cell lymphoma and lung cancer. And none of them have anywhere close to 30% like head and neck cancer, like HPV-associated head and neck cancer. It's only about 15%. So the really remarkable thing to us was that uterine cervical cancer, which is also caused by HPV, does not have inactivated mutations in these genes. So low percentage of alterations overall and some amplifications and some deletions. So it made us think that head and neck cancer may be different than uterine cervical cancer. So when we looked at these tumors, HPV can exist inside the cells in two forms. One's integrated into the host genome, and the other is episomal, basically is a circle, just like the viral genome's a circle. Uterine cervical cancer typically is caused, the typical pathway for having cancer formation in uterine cervical cancer has been described as HPV infects the cells, and then when it integrates into the genome is when the cells turn into cancer cells because there's increased expression of the HPV oncogenes. When we looked at head and neck cancer, we saw a large percentage of these tumors did not have integration. So when you sequence them, you don't see integration, you only see episomal forms. And if you look at the ones that have the mutant TRAF or CYLD, a lot more of those have no integration. And if you include tumors that have both integrated and episomal forms, almost all of the tumors with mutations have some episomal forms, and almost none of the tumors lacking mutations have episomal forms. So what we think we're driving at here is that not only is head and neck cancer caused by HPV a new type of cancer, because HPV is now causing head and neck cancer in addition to uterine cervical cancer, we think there may be a new mechanism by which HPV is causing cancer by not integrating, but maintaining an episomal form, and mutations in these genes allow that episomal form to be maintained. All right, so here's the real kicker. When we look at tumors that have mutations in these two genes, TRAF and CYLD, that are HPV positive, so the HPV positive tumors that have mutant TRAF and CYLD are these red ones. And if you look at survival, their survival is much better than HPV positive tumors that are wild type in these two genes. And the black line is the HPV negative tumors. So the HPV positive tumors that have wild type TRAF and CYLD, basically their survival is just as bad as HPV negative tumors, and all of the survival benefit in the HPV subset is related to having mutations in these genes. Now, we've found some other genes that have made this profile even a little bit better. Not going to discuss that today, but the value of this for clinical care is we think we can identify the population where we can safely de-intensify therapy. Because if we know those patients that are going to do well, we can give them lower doses of radiation, lower doses of chemotherapy, or maybe just treat them with surgery and avoid all of the radiation and chemotherapy. So ways that we de-intensify our surgery with TORS, which is TransOral robotic surgery, and then post-op therapy will be guided on what we see at the pathology. Radiation alone, and we can decrease the dose or decrease the fields. In other words, not treat as large an area and treat it with a lower amount of radiation. And then neoadjuvant therapy, which means giving them chemotherapy and seeing how the tumor responds. And if it responds well, giving a really low dose of radiation therapy. And then, of course, there's new therapies that may target particular vulnerabilities of these tumors that have episomal HPV. So I just want to show a little bit of how TORS works. We just have some still shots, but basically this is a patient, this is in the OR, and what we're looking at here is a mouth holder that holds the patient's mouth open so that we can get a scope into the patient's mouth and instruments from the robot that can go in there and basically see the tumor and remove the tumor. So we don't have to make neck incisions to take out these tumors. We take them out transorally using the robot. And this is how the room is sort of set up. The surgeon's sitting at the console. There's an assistant that's sitting at the head of the table that can see what's going on. This is the robot all draped out to make it sterile. And then the OR staff can also see what's going on. But basically, this is what the surgeon's looking at. And the tumor was here and is being pulled over this direction. And this is the endotracheal tube going down the throat into the larynx and into the lungs. And this is a electrocautery that's being used to remove this tumor from this area. So it's pretty remarkable progression from having to do surgery where we have to basically split people's mandible and pull their jaw out of the way to get to this area. So now we can do it with angled scopes. And this is a guy that had this surgery. He makes his living by talking to executives at companies and going out to eat and things like that. So he didn't want radiation therapy if he could avoid it. And basically we ended up doing a transoral robotic surgery and a neck dissection, and he had favorable pathology, so that's all that he got. And he's advocating for people getting screened and, for head and neck cancer and understanding this tumor. So you can see he looks like a pretty normal person. You know, we did his surgery through his mouth and took out lymph nodes from his neck. Worked out pretty well for him. There's a lot of innovation going on in this area right now, but I think we're moving more and more to how we appropriately personalize therapy for these patients, and that's really our goal. So I'm happy to take any comments or questions about that portion before we get into a little bit about some of the career pathway stuff. Anything on the chat, Sloan? If not, I can go ahead, and if something comes up, we can come back.
Yeah, there's nothing on the chat right now.
Okay, all right. So I just want to talk a little bit about my career. And you know, my career really started at UNC. I was an undergrad here and went to med school here. And so I had my first paper in Frank French and Betty Wilson's lab. It was a molecular endocrinology lab. And so I clearly did not go into molecular endocrinology. So, but what a great experience, you know. I worked there over a summer through the week. And then I went to Charlotte for the weekend, and I worked at a PVC pipe factory, basically, that made PVC pipe. And then I came back to Chapel Hill and worked in the lab through the week. Yeah, made the most money I've ever made. Got paid time and a half for the factory work on weekends. So, you know, it was 12-hour shifts, but it was a great experience. And, you know, I continued to interact with this lab, and it's just something that, you know, once you develop relationships with somebody, they were both great mentors. And so in this lab, we basically found the mutation that caused testicular feminization in the rat. And so testicular feminization is a condition. It occurs in humans, of course, too, but there was a rat model of it. But what it is it's people who are XY chromosomally, but because they have a defect in androgen signaling, they basically develop as a female because androgen signaling is required for male sexual traits. I was able to do this because there was a guy here at UNC at the time named Ed Lieu. Ed Lieu now leads Jackson Laboratories. Jackson Laboratories is a company that is very well known for, they do lots of things, but they're very well known for their distribution of animals, mice particularly, and genetic mouse models and things like that. But anyway, Ed Lieu's lab was doing PCR, and I was in the Wilson French lab, and we had this testicular feminized rat, and PCR was new back then. So I said, hey, there's this guy doing PCR over there. Why don't I take this rat DNA over there and see if we can amplify the androgen receptor out of it. And we basically found a point mutation that causes testicular feminization in the rat. And then later that year found it in humans as well. So yeah, it was a really, really great story. And I continue to interact with Ed Lieu as well. I was in his lab for a little while later on. And during my time with Ed Lieu, we found that head and neck cancers have a mutation in P16 that inactivate it, and that there's families out there that have mutations in P16 that are predisposed to head and neck cancer. So there's a familial head and neck cancer that's based on absence of this gene, and absence of this gene also predisposes families to melanoma. During that time, we were working on P16, and we found that there was another RNA transcript that hybridized that had the same sequence as P16, and we didn't know what it was, but we started working on it, and we found out it was a protein that ended up being called ARF, or P14ARF in humans, and ARF stands for alternate reading frame, because even though it had the same sequence, it was translated in a different reading frame, so it made a totally different protein. And we found out that ARF regulates P53. That was with Yue Zhong lab, in Yue Zhong's lab. So we started working on that, and then we worked on a protein that regulated ARF called LZAP. And we also found out that LZAP regulated NF-kappa B, and worked with Al Baldwin on that. So y'all can, I go through all this basically to tell you, none of this is done on your own. Basically, all of these people, Betty Wilson and Ed Lieu and Yue Zhong and Yanping Zhang and Al Baldwin and Chuck Perot, who had just come to UNC and basically was doing gene expression work. So with Christine Chung, we started working on head and neck cancer, and basically discovered subtypes of head and neck cancer that mirrored what Chuck had found in breast cancer. So, I don't want to forget Neil Hayes. Neil Hayes was here at UNC until about 2 years ago. He led the head and neck cancer TCGA effort. But you go through and meet all these great people, and both as mentors and as colleagues. And that's really the key to try to, get to where you need to be. So I wanted to just talk a little bit about some impactful and difficult decision points that during my career, and maybe, y'all will also come across, is, where do you go to college? That's always the first big one. And then when you do go to college, what do you do? How do you decide what to major in? What are you interested in? And once I choose a major, what do I want to do with my life? That's sort of the big one. I highlighted that because that's kind of tough, because I think very few people know what they really are called to do. There's a few lucky people that do, but most people, it's a little bit of gaining experience to inform your decision, but until you have that experience, you can't inform that decision. And then what if I'm wrong about what I think I want to do? And I would say that there's lots of pathways inside different careers that you can shape to match what you really have a passion for. And how do I find the right mentors? and I'll get to, I think, some keys for these things here in a second. And when do I move for opportunity? You know, whether that's from, you know, training lab or to another school or to another job. And what do I need to do to accomplish my goals? Do I need more training? Do I need more school? Do I need more techniques, more courses? You know, all kinds of things like that. So I guess just 3 takeaways as I started thinking about all those decision points in my career is, you know, what I think works, at least worked for me, is work hard, try a lot of different things, be nice, and enjoy what you do. And try not to worry. You know, not everything has to be planned out, and not every experience will be a success, but it still can be enjoyable and it can move you forward. And lots of times those failed experiences can help you in the future just by the people you get to know and by what they have to say about you. So meet and engage a lot of people. So mentors and colleagues, and try to meet people who are doing something that you admire or that you may want to do. And I think that's really best done through showing them your value through your interest and commitment, hard work and drive and self-motivation, and learn from these people. You know, most people, especially at institutions like UNC, are one of the reasons that we are here and that they are here is because they really like that interaction and really like teaching. And you can also teach them things as well too. So, you know, I learned, you know, a lot from my students and trainees. And then make decisions based on what fulfills you, not necessarily what's easier or what makes more money or what someone else wants for you. And then at the end of all that, your path or your career will be less work and seem more like fun because it's really what you want to do and what motivates you. So I don't have a lot else. I do want to just talk about the people who do all the work. So these are people we interact with. And the UNC Head and Neck Oncology Lab, we started when I came 2 years ago. Natalia Isaiva and Gary Bellinger came with me, and then other people have joined the lab since then. We still interact with people at Yale, and there's a SPORE grant, which is a big grant to support research on head and neck cancer that's led by Barbara Burtness there. We have a project on that. And you can see other people that we interact with at UNC. We have a NUA1 grant looking at markers for predictive markers for head and neck cancers that I was talking about, TRAF and CYD, with Bisham Chera and Gaurav Gupta. So work quite well with them. And then Blossom Damania, you know, is the Dean for Research in the School of Medicine. And we work with her on some immunology related work related to HPV. So happy to have some chatting time. I know that y'all may have questions or just discussion.
Dr. Yarbrough, you're an MD, correct? You don't have a PhD?
Yeah, that's right.
How did you choose a lab coming to UNC or had a lab?
How did I choose a lab when I was at UNC, like during my training?
Yes.
It was random, I would say, fairly random. I was pretty fortunate. So when I was an undergrad, I was doing an honors thesis in chemistry, but I knew that I was more drawn to the biological sciences than I was to straight chemistry and doing like NMR or, you know, other chemical reactions and things like that. So I asked if I could do something in the biological sciences for an honors project, and they agreed to let me do that. So I went and talked to a couple of people. The first person I went and talked to had just talked to a student that he was taking in his lab to do carcinogenesis research. So I was pretty disappointed. I thought I'd missed out on something. But then that's when I ended up going and meeting with Frank French and Betty Wilson. Now, this was a molecular endocrinology lab. And like I said, I'm not doing molecular endocrinology, but I sure learned a lot, about molecular biology and about cell biology and about biochemistry, and really dug in. And I worked in their lab for several years. They sort of shifted a little bit more towards prostate cancer, but at that point I didn't really know whether I was going to go to graduate school or whether I might go to medical school. But I talked to Betty Wilson and Frank French and a lot of people, and they basically said that if your primary interest is biological sciences, that going to med school you can still have that career in med school with a medical degree, but you also have the opportunity to treat patients and do clinical things as well. So I don't know. I guess I always say it's a little bit of luck and a little bit of a random walk to find your way, and having some good advice and I think just not getting involved in something and finding out whether or not you enjoy it is really the key.
So if you were more research oriented in undergraduate, what was kind of your tipping point to decide you wanted to do medicine and work with patients?
I think the thing that I found myself being most interested in on the research side was always related back to some disease or some patient problem. And, although I like the straight, cell biology and the straight, molecular biology stuff, I really enjoyed those things. And, I cloned this protein called sex hormone binding globulin, and we found out what it did and all kinds of things like that. But it wasn't really related to any pathology, that we knew of. And so I always just thought it was more interesting when something was related to a human disease. And that's what made me really start thinking about med school, because I thought, and I didn't know what specialty at all before I got into med school, but I thought I would be able to connect something with what I do in the clinical world with answering questions on the research side. And that's really what interested me the most. Now, I've worked with a lot of people who that doesn't interest them at all, they would much rather do, the straight, research. My son's the one that graduated is in physics. He doesn't want to be anywhere close to a patient. He's doing particle physics and, hopes to never see a patient, right? So I think for everybody, you've got to sort of figure out, how you're going to connect what your interest is to, the broader world out there. And different things are for different people, and there's no right answer. It's just whatever, engages you.
Dr. Yarbrough, you mentioned the outlooks for people with head and neck cancers that are HPV positive and HPV negative, and you mentioned that, we might be able to, at least the outlook is that we might be able to let up on this, toxic treatment of these cancers for some patients. Does the research tell us anything about who we might have to get more aggressive with?
Yeah, I think it does, and that's an excellent question because, you know, most people in the field right now are really slanted to who can we de-escalate. And the reason for that is we're treating patients with a lot of radiation and at the same time giving them a DNA damaging agent, cisplatin. And we know there's emerging data out now that patients 10 years after that treatment are dying, not from their cancer, but they're basically dying from side effects of the treatment even 10 years later. So that's why people are focusing on de-escalation. But the other side of that coin is exactly right. There are patients who are dying of their cancer because we're not adequately treating it. And so I think that if we can identify patients, and I think these markers that we have will identify patients who are not going to do as well with the standard therapy. We do need to figure out something new. And our lab also is working on that. So we have a couple of treatments that have actually made it to clinical trials already and are being tried. One's a demethylating agent that has shown pretty great efficacy in very small numbers of patients based on molecular changes. And the other one is a PARP inhibitor, which y'all probably or may be familiar about. People are using that for breast cancer that is associated with BRCA mutations. And they respond quite well to PARP inhibitors. And these tumors do too. We haven't opened that PARP trial yet. It got approved, but we haven't enrolled patients. And with my move down here from Yale, we may have to reboot that with a different plan.
So I'm still really interested on your path going through all of your professional school. Going into med school, if you knew you were interested more in biological disease, what kind of steered you to otolaryngology and HPV?
Well, HPV was totally out of the blue, and that was just because we were working on head and neck cancers, and basically that disease started, it was first recognized around 2000, and that's about the time my career started. So that was just serendipity. But we were studying head and neck cancers, and then this new disease sort of comes up. So we started studying that. Now, why I got interested in otolaryngology, you know, it's hard to totally put your finger on, but, you know, as you go through medical school, a lot of people pretty quickly decide, are they a surgical type or are they a medicine type? And I decided I was a surgical type fairly quickly. And then I was at UNC, and there was such a strong otolaryngology group. And the people were happy and they liked what they did. So, you know, I think if there had been a bunch of miserable otolaryngologists who didn't like what they were doing, I probably wouldn't have chosen it. But they were happy. They did like what they did. And what they did was really intricate, and the anatomy was really complex, and there was a lot of high stakes. You know, if you think about it, the smallest tumors we treat are about 2 centimeters. That's a T1. And if you measure 2 centimeters out, it's about an inch. So if you think about a ball that's an inch wide, and you figure out where in your body you would like to put it, and somebody's going to have to cut it out. And with a margin, you know, another centimeter on each side margin, very few people put it in their mouth or put it in their nose or in their, you know, most people, you know, might put it on their leg or on their arm. So we deal in some high value real estate up in this area because, you know, there's a lot of critical stuff that goes through here. And, you know, you cut out 4 centimeters of somebody's tongue, it affects how they speak and how they swallow. It affects their life. They can't cover it up with a shirt. You know, it's like if you have one in your lung, okay, you take out a lobe of your lung, nobody will even know you had that done probably. Now, lung cancer is a terrible thing. Don't get me wrong. But if you had to choose where somebody could cut out a 2 centimeter lesion, which is the smallest tumors we see, the head and neck's not where most people would put that. So I was really, just intrigued by all of that. And, the more I got into it, the more intrigued I got. And at that point, I knew I was interested in cancer from a research standpoint. And I was really interested in head and neck cancer because at that point, there were not great treatments for it, and reconstruction for it was also lacking. There's been a lot of tremendous progress over this time. So now the treatments are very good. The survival for HPV negatives is still not great, and we still need better therapy. And the survival for HPV positives, sort of like, we discussed here, there's a subset that's really good and there's a subset that's not so good.
Through your professional career, I've noticed that you keep coming back to UNC, even though you got positions at Vanderbilt and Yale. What brought you back to UNC?
It's really, I think all of my moves, first to Vanderbilt and then to Yale and then back to UNC is really just based on opportunities. And, when I say opportunity, it means what can I contribute, and what position can I have to try to advance things. And so, that's really what drives me is, I like building things. I like having the opportunity to make the biggest impact. And that's really what brought me back to UNC. UNC is a great university. The Otolaryngology program here, as you can see, is one of the top ranked in the nation. The UNC, y'all probably heard about the research funding for UNC, and now it's crossed $1 billion a year. More than half of that's from the School of Medicine. So as a research institution, there's huge opportunity here. And I already interacted with a lot of people here just from my from being here in prior years. So, it's just hard to imagine, a better job where you can have a bigger impact than coming to a program like this.
Does anyone else have any questions? Or if you do, you can put it in the chat or you can just ask them. If not, thank you, Dr. Yarbrough, so much for coming. This was a great talk. I did really enjoy it, and I'm sure everyone else did too. Our club really appreciates you coming and speaking to us and giving us your time.
Happy to do it. And if y'all have more questions, feel free to contact me, offline, or if somebody didn't feel comfortable speaking up in the group, just feel free to contact me. I'm always happy to talk about otolaryngology or research or HPV or all of those things.